delay. So, like all the previous speakers have already spoken, this is a very, very exciting new drug. And let's straight away go to what is something that we have seen. Of course, this is the usual disclaimer and we all, I will not go through the introduction. We already have gone through that. The important thing is the point which we are trying to make here is that, yeah. So we have this here. Yeah. So this is what we have. That there's a lesser time required to penetrate the retina because this is just 26 kilodaltons. Besides the other pharmacological differences that this drug has over others, and therefore the half-life can also be longer, and it can penetrate deeper in between these spaces, which the other larger molecules cannot. So this was the study, which was the Hawk and Harrier trial. We are all aware that the Hawk trial had 2 doses of 3 milligrams as well as 6 milligrams. So what was found was that 3 milligram is very effective, but 6 milligram on 12-week dosing, 6 milligram on 12-week dosing was as good as 8-week dosing of aflibercept. And you can see that the best corrected visual acuity was similar, and the proportions of eyes with persistent intraretinal fluid, the significance of which has already been spoken about, is here. So there is less intraretinal fluid with the 6 milligram. 3 milligram is also doing a good job, but in the Harrier trial, we had 6 milligram of brolucizumab, which showed that the intraretinal fluid that it can decrease is less than aflibercept does in 8 weeks. So these are some of the patients I'll just show you. This was a gentleman who had already been injected brizumab 5 times, and despite that, he had a huge PED. And then we gave 3 more injections of ranibizumab, and finally, this was the appearance. After 5 times, this was the appearance, and this was the OCT. 5 doses of ranibizumab, and then again we gave an additional 3 doses here. And so this is the end result after 5 plus 3, 8 doses of ranibizumab. Finally, we shifted to brolucizumab, and look at this. Just 1 month after this is the kind of resolution we got. And then after the 2 doses of brolucizumab, almost a normal looking OCT. Similarly, patient 2, he had some fine lesions here in this region. And you can see the massive neovascular network forming in this region here. Right here, you can see, right? And you can see in the OCT also here. And this is just 1 month after this. Look at the massive resolution of all the neovascular net that was happening. Then another patient, best corrected visual acuity of 636. And the patient was straight away put on brolucizumab on 14. This was the appearance of the neovascular net here. You can see this is a 6x6 angio-OCT. You can see the neovascular net here, and on the cross-sectional analysis, this is the situation. And so on 11th, we saw this patient, and on 14th, we gave the first shot. Just 3 weeks later, this is a 3x3. The previous one was a 6x6 OCT. This is a 3x3 scan, so it is more kind of zoomed in. And you can see that after the first dose itself, very significant resolution has taken place. So we continued the treatment up to 3 injections, and then we found that this was the stable situation, and it was neither improving beyond that nor getting any worse. As patient 4, this was CSRF with scarring, and this is the scar we had here, and you can see the cross section along with the scar tissue. There was significant amount of fluid, and we gave the brolucizumab, and this is the result after that. Patient 5. We have best corrected visual acuity of 648. First shot of brolucizumab given. This is the image. Look at this net, massive net here. And after the very first shot, this is the level of resolution we were able to get. Now, what I'm trying to say is that the resolution that we are getting with this drug is something I've never seen. I've been using Avastin from 2008. That we were among the first to start Avastin, VEGF in private. But this kind of resolution is amazing. So what the conclusion in short is that it is a very potent intravitreal anti-VEGF, and 6 milligram is definitely is better than 3 milligram, but 3 milligram is also very effective. And like we have the other studies, like the Marina studies and all, which talk about side effects, which is beyond the scope of my discussion right now. But like the previous speaker has said, that we need to use it judiciously and with care. And once in 3 months dosing seems to be quite fine. It seems to, even the loading dose we could probably change from once a month to once in 2 months to begin with. Thank you.
Thank you very much, Dr. Goel, for finishing on time. I'll have one quick question to Dr. Vishali. So, Dr. Vishali, would you recommend monthly loading doses in these? While it is recommended in your practice, do you think there is a role, given that also that right now there has been a recommendation not to give Q4 at least after the loading dose, but do you follow loading dose at the beginning?
To be very honest, I don't have this much experience to compare the loading versus non-loading dose. But a couple of patients where we have given the loading doses.
Okay, good. So in the interest